So, good afternoon, everyone. Or better to say hello, everyone, because for someone of you it's a morning, for someone is afternoon, for someone is already evening. So, hello, friends all over the world. Welcome to our second ESE live studio, and today we are hosting the president of the ESE, Professor Hal Duncan, who is not only the leader of the ESC Society at the moment, but also was or still is the leader of the S3 ESC S3 level guidelines. Hello, Hal. We are
Hi,
live.
hi, it's a pleasure to be on this call this evening and spread some of the information contained within the S3 guidelines.
So it's very nice to have you, and thank you for dedicating your time because it's a very busy time for you, I guess. The Krakow meeting is under full preparation, and you have just been there for a site visit. But the Krakow meeting is dedicated for S3 level guidelines. So we say that the meeting logo of a meeting title is S3 level guidelines, and we are going. The program is built on. Going deep into these S3 guidelines. So today we are going to decode these S3 guidelines, and the best person to do this is you, of course. So let me ask you the first question. The goal, of course, of this interview is to get deep into this topic in a clear and a simple way to explain what does it mean as free level guidelines. And we have now a new and unique, so far unique document created by the ESC. And that document has to replace an old ESC quality guidelines for endodontic treatment that was released in 2006. 18 years ago. Could you give a brief background on the guidelines in general and their importance for the dental practitioners?
Yeah, thank you, Laura. It's interesting because the original ESC quality guidelines for endodontic treatment was published, as you say, in 2006 in the IEJ. By at that time, by a state-of-the-art process. And that state-of-the-art process, this may not surprise anyone listening to this, was that a group of experts, presumably the board and one or two of their colleagues, wrote, by reference to the scientific literature, the best they could in actual fact, what was the standard of care expected of endodontic practitioners and those performing endodontics. What happened over the intervening 18 or so years is that this document became the biggest cited or the highest cited document in the International Endodontic Journal. So it's very popular. And it's popular because academics and practitioners and governments are always looking for references that they can base their treatments on. So these guidelines are very important. They're a way of distilling the research that we perform into meaningful guidelines that are evidence-based for the benefit of practitioners. What happened, and this is part of the process, is that the way of doing guidelines and even position statements is slightly outdated. It's been modernized because people have commented that, hold on a minute, Hal Duncan from Dublin and Laura from Lithuania they're just friends. So this is just a bunch of friends writing these documents. You don't tend to choose your enemies to write things with. So for that reason, in many ways, you don't get the best balance of opinion. So with that in mind, this sort of, if you like, hierarchies of guidelines have been developed, going from S3 at the very top, way down to S2 guidelines. And I'll just explain a little bit about these levels. S3, which is the level we decided to perform, is a systematic approach. You systematically analyze the literature according to very strict criteria. You choose very precisely the sort of people who are going to regulate and adjudicate, and it's very closely related to what we would call conflict or declarations of interest. In other words, you cannot have people with conflicts who are dictating guidelines. As you can already tell in that very quick 2-sentence introduction, it's a complex process. And I don't think anyone within the ESE probably realised how complex it was. And for that reason, the The executive board at that time, which was chaired by Klaus Loest and Paul Dummer, was supporting him, suggested we should probably ask other societies, in that case the European Federation of Periodontology, who have done this type of review before, to give us a help. Because we needed a methodologist and we needed a sort of co-leader who was familiar with carrying out these type of guidelines. So in that sense, we recruited Maurice Kebskill from the University of Birmingham, who'd done this for the EFP, and Ina Kopp, who's a methodologist who's worked on guideline development for many years within Germany. I have to say at this point, these people were invaluable to the creation of these guidelines because they kept us right methodologically the whole way through the process. And in the end, these guidelines, which were took from start to finish 3.5 years to generate, are actually quite a complex and meaty but substantial guideline. Why this call is important and why Krakow is essential is because for practitioners, very few people will wade their way through 100 pages of recommendations.
Yes.
So what we're trying to do is decode it, demystify it, make it more relevant, talk about the weaknesses and the strengths of what we do as a discipline, because it isn't just there to guide endodontists and general practitioners and dentists on how to perform root canal treatment and other endodontic procedures. It's also there to highlight what we could be doing better, what research we are deficient in, and also where we should probably be going as a profession within the next 10 or 15 years. I hope the guideline will serve on multi-levels, that being just one of them.
Yeah, so I'm putting the reference for the S3 level guidelines. So they are already published and there is a special issue in International Endodontic Journal. So everyone can look at it because it's free access.
Yeah, and in that special edition, you will find the guideline and you'll also find 14 systematic reviews. These 14 systematic reviews inform the recommendations. The systematic reviews were performed by 2 leaders from different jurisdictions. In other words, one from Germany, perhaps, for example, one from America, one from Australia, one from Denmark, who hadn't worked together before, and in many cases, would not have been obvious bedfellows or people that could have worked together. The reason for doing that is, again, to try and get away from this narrative bias, expert-led opinion. So there's 14 systematic reviews, and there's, if you like, cajoled or divided into 4 working groups. The aim of this guideline at the start was to look at vital pulp treatment, pulpitis, the treatment of pulpitis and vital pulp treatment, the treatment of apical periodontitis, 1 non-surgically, that was working group 2, surgically, working group 3, and also with new revitalization and tissue engineering approaches, working group 4. The working groups were not of equal size. Working group 2 on non-surgical treatment of apical periodontitis was by far the biggest, but each group was set up the same way. There was 2 working group leaders for each working group who were experts in that area, but again had not worked together before. For example, working group 1, the treatment of pulpitis, was Ikhlas El Karim from Belfast and Gabriel Krastel from Würzburg in Germany. Working group 2, which was the non-surgical treatment of apical periodontitis, had O.V. Peters from now Australia, was San Francisco, previously Zurich, and also Lisa Lotte Kirkevang from Denmark. Group 3, working group 3, Bunsong Chong from London, formerly Guy's, now Queen Mary, and also Massimo Del Fabbro from Italy, who very strong interest in both systematic reviews and surgical treatments. And finally, the regenerative group in revitalization and tissue engineering had Kirsten Galler, who has written a lot in this area, and Juanjo Segura Aguirre from Seville. So a balance of really well-known European and further afield people leading these groups, and within each group, a series of systematic reviews, which therefore informed the guidelines. And you'll find all that information within the special edition, volume 56, issue 3.
Yes, so it took more than 3 years, to formulate this document, which is already published. Because as I can see, there were 20 online meetings, probably much more in a group discussion, and 3 years for final publication. It's a very complex work.
Yeah, I think when I agreed to do this, Laura, I would probably not have agreed had I realized how much work it was going to be and how long it was going to take. It almost turned into a PhD project, a second PhD project for me. And in some ways, I understand why the amount of work was necessary, but at the time a lot of us were unsure why it would take so long. And it's very important at the start that you do set a timetable, because it's very easy to let time drift. I mean, immediately the first thing we did, and we did this quite quickly, is we organised our 4 working groups, as I've previously described. The working group leaders, in conjunction with myself and Maurice Kebsco and Ina Kopp, devised the systematic reviews, in other words, the question we wanted to answer within each working group. Then we chose reviewers from a pool of reviewers, and they were invited. But you can imagine at that point, some reviewers are quicker than others. So it has to be, the systematic review has to be written, the PICO and the questions and the review has to be pre-registered in Prospero. So you have a pre-registration, it would be the right process. Every author and every working group leader has to submit a declaration of interest on a standard form. We then have to meet in several groups, Zoom calls, to make sure we're all singing from the same hymn sheet. In other words, we're all agreeing exactly what we're trying to do. We're all going to use the same process. We're all going to measure the same outcomes, which if you think about it for a moment, if you think about endodontics, what outcomes are we going to measure? We have to standardize these outcomes. In other words, we have to say we're looking at radiograph as the most important. We're looking at tooth survival. We're looking at pain, post-operative pain. And all these outcomes are not standardized within our discipline. We are now developing core outcome sets, but at the time of writing these guidelines, there was no core outcome sets. So we had to first of all start with a paper which basically standardized outcomes. And then you've got to standardize when you observe the outcomes, because we all agree that for apical periodontitis, radiographs are essential for monitoring. But you, Laura, might disagree with me. You might say 6 months is adequate. Somebody else might say 4 years. So you've got to choose a time point, a minimum and maximum time point. And we chose a minimum time point of 1 year follow-up, but with this maximum as long as possible. So that immediately excludes quite a few studies. The same for vital pulp treatment. Post-operative pain, we said 1 week was the minimum, up to 3 months. So that again excludes studies, because a lot of studies are at 1 day and 2 days. So you have very strict inclusion criteria. You also have inclusion criteria relating to the type of study. They have to be comparative studies, randomized control trials, or cohort studies, or non-randomized control trials, but nevertheless, they have to be comparative. And if you just stop for a second and you think about all the studies we have in endodontics at the moment, and we've all read them, a lot of them are single-arm studies. So they don't have a comparative. So a lot of these studies were not acceptable. And the reason they're not acceptable, this was according to the methodologist, is that you cannot any longer have a study which recommends a treatment if it isn't compared to something else. So that was a bit of a shock, and it's something we have to think about moving forward as a profession and as a group of researchers, is in the future, are we actually carrying out, planning and administering the right type of studies which will be eligible for this type of guideline in the future? So you can already see, and this was in the first 6 months to a year, my goodness, there was a lot of organization, there was a lot of calls, there was a lot of sleepless nights, there was a lot of, I feel like a sort of off the ball comment. Some reviewers got on very well, some reviewers didn't go on at all. So you have to some extent be a marriage counsellor, to some extent also when you're leading a guideline process, because most people in the end got on, but it was a struggle for some groups to work together. As you can probably imagine, other groups worked extremely well and have continued to work afterwards. So once we got that position of the guidelines being written, and the reviews being written, they had to be submitted internally. And the reason they're submitted internally first is the working group leaders and the guideline leads, which was myself, Moritz and Ina, have to review them so that basically the structure is somewhat similar between each review. After the process, we look at that and we make sure everything is structured and similar. We then go through a second group of review, which is within the International Endodontic Journal, which is reviewed blindly by people who are not related to the guidelines. And really that's so we can actually say this is robust, very well, double peer-reviewed manuscripts. Once the manuscripts were all accepted, and that took quite a long time because some went to 3, 4, and 5 IEJ revisions. It's quite a time-consuming process. We then started to write the recommendations. In other words, from the review, is additional or adjunct therapy useful in the treatment of apical periodontitis? There would be recommendations, perhaps, that one of the recommendations was that really there was very few studies which showed an outcome benefit for using ultrasonics. Let's just choose that as an example. or PAD, or phosphate-activated disinfection. So we start to write recommendations in which we write a bit of background, a bit of the type of studies, limitations of those studies, and some provisional recommendations. We do not think you can recommend, or we do not recommend the use of ultrasonics or adjuncts. And these were then, if you like, again standardized, written, discussed in online meetings, actually for each working group, 4 online meetings to discuss these guidelines, to get the wording absolutely correct. And then afterwards, we went to a consensus plenary meeting in Lisbon in January 2023, which, with under the methodological lead of Ina Kopp, for 2 days, quite intense days, we actually discussed every recommendation, first within working groups and then all together, and then we voted on them. And at the end of that process, we decided what was going to go into the final review. So I'm actually tired talking about this. So you can see it's quite a long process, but in the end, quite a robust process, which gives us some really quite interesting recommendations.
Yeah, so this will be actually in details discussed in Krakow from the different perspectives, from 2 different perspectives, from the clinical point and from the scientific point. And so the Krakow meeting program is, I would say, also very unique. And I will just share the screen again, just to show you the summary of the program. So you can see that we have 4 topics in one hall and 2 speakers for each aspect, for each topic, from different aspects, clinical aspect and research aspect.
Yeah, and I think this is really important when you have guidelines. This is a really nice program because there'll be a Krakow. We want to be attended by a broad representation of people interested in endodontics. In other words, we don't just want a group of academics who are there to discuss if the instrumentation studies we have are adequate, or whether these type of files remove biofilm better than those. Another type of, what we're also wanting is the really clinical aspects. If we make a recommendation which says that it doesn't really matter which type of nickel titanium system you use, we want some clinical input into that, to what does, from based on the guidelines, actually maximize our outcomes in terms of treatment of apical periodontitis using instruments. And some of this will be very much focused on practical and clinical considerations, while other parts will be focused on the research and the research deficits. So unusual, something we've not tried before, something I've probably not seen a little bit before. So, but looking at the range of speakers, a really, really good array of speakers, I think it will be a very exciting 2 days. And uniquely for this meeting, which we've not done before, Laura, as you know, is we're all going to be in this one place. You can't dip off to hall 5 or hall 4 or hall 3. We'll all be in the same hall. So I think in terms of a sort of camaraderie and togetherness, I think that's really nice to all be in the same place so we can discuss the same issues at the same time.
Yeah, and I think we also expect the engagement from the audience, because the clinicians and the scientists will be there, and probably they will have questions why for example, some recommendations are not complete, and probably some scientists should be also interested in gaps that might direct future research and to fill those gaps.
Well, I completely agree, and I hope people do speak up and interact, because part of one of the real drives for having this 2-day session in Krakow is that it can be a stimulating conversation. Lots and lots of people contact me asking me questions about the guidelines, some of them challenging some of the results, some of them saying they don't agree with the results, some of them saying they think they're the best thing they've ever read. And I think it's important we have that discussion. I think this is a good place to have it. Let's get together. Let's discuss what we agree, what we don't agree, and we can explain why we actually made those recommendations, because some of them may be clear, some of them less clear. So we have to probably have that conversation together.
Yes, and as you said, the guidelines are not a static document. So this is under development, let's say, yes?
Yeah, I completely agree. I mean, I think any subject is, we hope, endodontics being absolutely no exception, should be dynamic, changing, and respond to challenges and things like guidelines. I mean, we've basically highlighted in some areas that there's no evidence, comparative evidence at all, or some of the most important questions we might have in endodontics. I have
Mm.
highlighted this before. Should we expose the pulp? Should we not expose the pulp? It's a very, very divisive and emotive issue in endodontics. We don't actually have answers to that because we've no comparative studies comparing those or looking at those. So yeah, I think there's some really interesting things that this has highlighted that we probably need to address in the next 10 years with quality studies.
Yeah. So, any future plans? Do you know how? Do you have any plans how to translate those, to
Wow, yeah.
disseminate all those guidelines among societies, educators, and
Well, Lord, I think that's the great question and probably the most important question. I think if we look at this guideline development, they have a roadmap. And on this roadmap is this thing called adoptment, which I didn't really
yeah,
know what that meant at first, to be honest, but I think it really means adoption. And there's several layers of adoption and adaptation and how we spread this word. And one of the first things we need to do is I am people who listen to me probably don't think I speak terribly good English, but English is my first language. And so therefore I'm a little bit arrogant that believing that everybody speaks English. Of course, they don't speak English. So we have to look, first of all, in a reasonable manner at translating these into certainly most of the large countries within Europe, first of all. We have approached some smaller countries, for example, Norway, and Norway said, actually, most people in Norway speak English.
yeah,
We're not maybe the first place you should come. So we have gone to some of the other larger countries like Germany, Italy, France, Spain, actually Poland. And we've gone to these, and nearly all of those countries, someone has agreed to translate or help us with translation there as well. We've also gone to China. Okay, not a European Society of Endodontology member
yeah.
country, but nevertheless, the Chinese were very interested in these guidelines and actually volunteered to translate these for us. So anybody who
As
does
well
that
as
is
Japanese
great.
ladies as well. Yeah,
Yeah,
yeah.
we have
We
Japanese
really
as
fit.
well. So I absolutely
Mhm.
agree that the broader we can spread this, the better, because people need easy, simple to read versions. They need congresses and conferences. They need online webinars and presentations, but they also need to have it seen and written in their own language, and that's the first process. What also can happen as a result of that, and it's worth thinking about this, is that the recommendations we make as a European group may not completely apply to every country. For example, in Lithuania or Italy, there may be different healthcare systems, which mean that you can't actually follow the recommendations quite the way they're written. So there is an option of adapting the guidelines for local countries to make them more relevant to your
Mhm.
own systems and processes.
Okay. So we have also to introduce Monica Freire, who is our COO of the ESE, and she was all the time in the backstage, but she is very important and very supportive. And she was looking at the questions and comments. Monica, can you add something? Maybe we are missing some important points in our conversation with Hal, or maybe we have received a very interesting comments or questions or ideas and recommendations. We are here to collect all these issues.
Hello, everybody. Yes, and welcome. Thank you so much for joining us tonight. We have some interesting comments here live. One of the questions comments are the guidelines an indication to the standard of care in Europe?
Well, it's a reasonably good question, and I'll tell you why that's an interesting question. These guidelines were designed to address how we should optimally and effectively, and from a research-led, evidence-based perspective, treat the two main diseases in endodontics, pulpitis and apical periodontitis. What they don't, and we didn't think, we do it in some of the background text, but we don't do it up front, is that one of the problems we have in endodontics in Europe and abroad and further afield in Europe is that it's very often carried out to quite a poor technical standard. Most cross-sectional studies in root canal treatment would show that, and vital pulp treatment now would tend to highlight that these is not carried out well. Throughout this guideline, in addition to the evidence-based recommendations, which I've spent most of the tonight talking about, there were also some expert-based recommendations. And these were linked to things like the use of a strict aseptic technique, the recommendation to use magnification, the recommendation to use rubber dam or dental dam, the recommendation that for some root canal or endodontic treatments, you may require a postgraduate qualification for some of the more complex stuff, for example, like surgery or advanced-free treatment. Not that you had to have, but we would recommend that it may be something that would be beneficial. So we do make broad comments about how we should be carrying out root canal treatment to get the best results. And we also allude to the fact that in the past, root canal treatment has not always been carried out optimally. So to answer that question, yes, we do comment on it. It is not the focus of the document, but what is the focus of the document is how we can improve endodontic treatment moving forward. So really we have to think about how we teach it, how we implement it, and what sort of basic standards we set. Because, for example, rubber dam, you will not find a randomized control trial with patients with rubber dam and patients without rubber dam. However, we all accept that rubber dam is very useful for keeping an aseptic field, to maintain quality of your work, to stop saliva getting into tooth, to prevent files getting dropped into the patient's throat. So we all see the wisdom of rubber dam, but for obvious reasons, we would not have got an evidence-based guideline on that. But we did give an expert-based recommendation on that topic, amongst others.
Yeah. We have one other question from Ghassan Yared, who's asking, any joint work with the AAE read these guidelines? And if not, why?
Hey, it's a great question. We have I want to be fairly clear about this. It's looked as if in recent years with the vital pulp treatment position statement and subsequent AAE position statement and vital pulp treatment, they were sort of semi at war with each other. That's not strictly correct, actually. We differ on certain issues related to caries removal in those documents, but by and large, the vital pulp treatment documents say the same thing. We wrote a letter after the AAE published their statement to say it's not terribly useful to continually keep producing parallel documents. After all, Gasa, you'll know that the same thing has happened within core outcome set development. In fact, it's the very opposite of useful for patients because they get conflicting advice very often from two very reputable bodies. So what we're now looking at doing, and for the first time we've actually managed to do this, is we're now got some joint working groups looking at issues related to classification of disease. And the AAE are working with the ESE on this. It's baby steps a little bit, because what I didn't realize, but you will of course realize, is that the American system is very focused very often on insurance codes and the type of treatments they do, where the European system is a little bit more based around disease. So there are challenges of working with the AAE group in this, but I think it's absolutely essential. If we're really thinking about dentists and we're really thinking about disseminating a proper message, including dentists and patients, I think we have to get together, not just with the EE fun enough. I think we probably have to include groups from Asia. We have to include South America as well, and Oceania in this as well. But yeah, absolutely. Couldn't agree more. That's the way forward.
Thanks.
Monica? We're having some comments on the importance of the translation of the guidelines. We've had some people commenting on that. Are there any plans, or are you accepting volunteer work towards translation?
Yeah. I mean, it's absolutely. See, this was a question that was asked recently. Somebody said, "Oh, come on, artificial intelligence is so good. Could you not just translate these guidelines into multiple languages with artificial intelligence?" Yeah, you could. The problem with that is that you would probably miss some technical nuances. They could be misrepresented. So that reason we've gone direct to societies to help translate the guidelines. For example, we've gone to Polish Endodontic Society, or we've gone to Spanish Endodontic Society. And within that, largely volunteers. Klaus Loos, for example, is doing it as a voluntary basis for the German, the DGAT and the German population. So absolutely. If somebody is interested in doing this and helping with this, absolutely let us know, and we would be more than delighted to try and accommodate in this, because really that's the only sensible way of getting it disseminated to as many people as possible.
Yeah, great. Any more questions, Monica? Just I think.
Someone is saying that, yeah, we need it for the Ukrainian Endodontic Society as well. Yes, well, the plans are to keep translating it as much as possible.
Keep translating as much as possible. And if somebody's from Ukraine, if you can drop us details and in contacts about that, we will try and set up something that we can get started. Because I absolutely agree with you. It is the way forward.
And that, as I can see, there are some questions that require more in-depth answers. So we can just say that we can meet all in Krakow, and you can really receive a very in-depth messages from the clinician and also from the scientist, and also to have a conversation live with the lead Hal and other people involved in these guidelines, and they really can answer your questions, and you can have a valuable discussion in both sides for the ESE S3 guidelines group, and also for the clinicians and also the scientists. This Krakow meeting is meant to be for this. Actually, this is the goal for the Krakow meeting, which is very unique in its structure, and also the first auto meeting which is open for everyone: scientists, practitioners, students, postgraduate students, academia, clinicians, and also for industry.
Yeah, I completely agree. I think it's also exciting for the very point you made. I think all of us, and I'm hoping this will be a good thing, all of us will be much more accessible. We'll all be there. We'll be present. There's only one hall. It's quite a nice. I think Monica would agree with me. It's quite a nice small venue that people can easily bump into each other, meet, have chats, nice open space in the middle. So it's an opportunity for people to ask questions. Maybe they've in Helsinki, when there was so many people about, it was hard to find people, but that will not be the case in Krakow. So I'm hoping it will be a friendly, personal, and we'll do our best, or I will do my best if I'm asked any questions to find somebody else that knows better. No, honestly, I will try my best to answer the questions.
Yes. So 16 speakers in total are waiting for Krakow meeting. Yes, we'll be discussing all those questions. So all are very welcome to join the Krakow meeting. And perhaps if we don't have other questions, we can summarize and close this meeting. Thank you, Hal, once again. Thank you, Monica, for your support. And thanks everyone who was watching. And I just want to remind you that the recording will be placed on the YouTube channel, on the ESE YouTube channel. There are much more important information over there, and you can watch it whenever you want. And let's see each other on the 18th of April with one of the Krakow speakers, Maciek Żarow from Poland, and we will discuss other questions. Thank you very much. Have a relaxing, good evening or nice day to everyone, and see you very soon. Thank you very much. Thanks.
Thank you.
Thanks for joining.
Yeah, absolutely.